I'm your host, Hank Warren, representing the Teleflex Standard Bariatrics team. We're joined this evening with Dr. Schram from Grand Rapids, Michigan, to discuss his experience with the anatomy-based approach utilizing the Titan 23 centimeter single-fire stapler for consistent and repeatable sleeve gastrectomies. Quick note before we begin. If you will please enter all your questions in the Q&A section at the top in the chat, and then we will address those at the end of the presentation at the Q&A session with Dr. Schram. So without further ado, I will pass it over to Dr. Schram.
Hank, thanks very much. Maybe you could just shake your head yes, you can hear me okay, and volume's okay, everything's good? Good. Well, excellent. Well, welcome to everybody. Excited to be here tonight and talk a little bit about my newest favorite topic, the Titan SGS. And as Hank said, I'm here in Grand Rapids, Michigan, and excited to talk about our experience with the Titan stapler thus far. You want to control the slides for us, Hank, and move on. As Hank said, we're in Michigan, Grand Rapids, Michigan. I'm currently the president of the Michigan chapter of bariatric surgeons, part of a group of 5 surgeons practicing in Grand Rapids and kind of throughout West Michigan. And I've been doing bariatric surgery for about 22 years now. So kind of one of the old guys, but excited about this new technology. And go to the next one. I do have a disclosure. Happy to be a proctor for Teleflex and Standard Bariatrics and do some teaching, obviously with regard to the Titan stapler. Next. Quick demonstration video here.
There is a better and more consistent way to perform sleeve gastrectomy. We call it the standard sleeve. It's an anatomy-based approach using a purpose-built Titan SGS stapler. Insert the standard bariatrics conical shape angularis protecting sizing bougie, or any sizing bougie, to serve as the guide for placing the Titan SGS stapler precisely in alignment with the key anatomical landmarks. Insert the Titan SGS stapler into the abdomen. Clamping as you go, manipulate the entire stomach through the stapler, from the fundus to the pylorus region. Respecting the key anatomical landmarks and the sizing bougie, the resulting cut line should be approximately 1 centimeter from the GE junction, 3 centimeters from the incisura shora angularis, and approximately 4 to 6 centimeters from the pylorus. From the top to the bottom, visualize the full cut line in a single plane. Fire the stapler. The Titan SGS continuously staples the entire length of the intended cut line with a single cartridge, delivering 6 staggered rows of staples in gastric tissue in less than 1 minute. Titan SGS provides confidence that an optimal, secure staple line is forming in gastric tissue, with localized tissue compression zones and larger anvil staple pockets. Titan SGS minimizes the chance of misaligned or malformed staples impacting surgical results. Titan SGS provides innovative longitudinal graduated staple technology. Each successive staple is taller, matching the entire length of the staple line more closely with the actual thickness of the patient's native anatomy. After firing the Titan SGS, the resected stomach falls away and the new stomach rebounds, revealing a more symmetrical and reproducible sleeve pouch anatomy. The curved staple line is a continuous staple line, free from zigzags, overlapping, or poorly formed staples. The Titan SGS enables the surgeon to plan for a more repeatable and reproducible procedure that delivers consistent sleeve pouch anatomy every time. With limited device technology, bariatric surgeons have been able to achieve the ideal tubular surgical sleeve anatomy less than 40% of the time, which can lead to inconsistent outcomes for patients. Now, with a combination of a repeatable technique and the purpose-built Titan SGS stapler technology, achieving a more consistent sleeve pouch anatomy is possible for your patient. Every patient is different, but with the new Titan SGS stapling technology, their procedure doesn't have to be.
Well, I think that's a really nice video because it kind of really demonstrates in a very short time a lot of the things that we're going to be talking about tonight. And I think it would be remiss for me to say to just say that the Titan SGS Stapler was developed and gained clearance by the FDA in 2021, because the development of this stapler really goes back nearly a decade ago when John Thompson in Cincinnati really first envisioned an anatomy-based approach to the sleeve gastrectomy, and then working with some incredible engineers from Ethicon, began to develop the concept, first of all, the clamp, and then finally the product that you see in front of you right now of this really great product. The beauty of this is that this is a powered single fire 23 centimeter stapler that fires 6 rows of staples with varying lengths. And those lengths are based on a lot of science, measuring hundreds of stomachs, the thickness of stomachs, to come up with an optimal varying from 1.2 to 2.2 millimeters over with 6 different staple heights. So we're really getting nice variability from top to bottom, which is, I think we're finding to be really one of the great points of this product. Produces a symmetric, reproducible gastric sleeve, which we'll kind of demonstrate in the next slide. It's introduced via a 19 millimeter trocar. It's fired with a special bougie. It's a 38 French bougie that has a balloon, water-filled balloon that holds 14 cc's of fluid that takes that 38 French to about a 42 French that we can have right at the incisura to protect that incisura from getting too narrowed. We find that this reduces operative time, obviously reduces staple loads, and there's that elimination of that staple load junction sites, between each fire that we all get nervous about. Next slide, Hank. This is just a short video of one of our cases. As we do as everybody does, we take down the blood supply to the greater curve. That now we advance that bougie along the lesser curve. We roll the stomach over, advance the Titan into the abdomen, and then we'll pull the stomach through, keeping in line with those landmarks that we talked about, 1 centimeter at the angle of His. That balloon allows us to be able to really nicely size at the incisura. We'll see that now the balloon's inflated, keeps us away from getting too tight at the incisura. And then we mark it about 4 or 5 centimeters from the pylorus and fire the stapler. Takes 55 seconds for that staple to fire from top to bottom. But with a single fire, it obviously saves us a little bit of time. And peel away the remnant stomach. And you have right there what we see every time, just a nice straight staple line. We, with our residents and fellows, we oversew that proximal, do a little omentopexy to the proximal part of the stomach. It allows our residents to get some sewing time in. And now that we're doing these mostly as outpatients, we drip the seal along the staple line, just so we feel more comfortable when we send these people home on the same day. So that's our technique for the past 2 years, and I'm getting excited to talk about that. So, I think every one of us, when we go to the OR with a patient, we're going to do a sleeve. Our goal is that patient on the left, just a nice, obviously straight tubular stomach with a nice clean staple line. But the reality is that when we're using a multi-fire technique, the results oftentimes can be what we see on the right, where the staple lines are a little bit twisted, or we've got some narrowing in some areas. And the product that we wind up achieving is not exactly what we'd hoped for. Next slide. And not only that, we got to make a decision about staple heights. And we're usually, using 2 or 3 different staple heights, blues or greens, blacks maybe on some guys. But the reality is we're picking between 2 staple heights for the most part when we do a stomach. And the stomach may not be optimal with just 2 colors. And so it would be ideal, I guess, if we could use more than just two different types of staple loads and have a staple load that's designed specifically for each height of that's, maybe scientifically designed for the depth or the thickness of the stomach. Next slide. So years ago, Toro at Emory did a study. They took 100 patients and they tried as hard as they could to create the perfect tubular sleeve on each one of them. And then they looked at those sleeves radiographically. And what they found was that only on 37% of the time were they actually able to identify what they considered to be a good tubular sleeve. And in 41% of those cases, they actually had areas where there was problems, either a larger upper pouch or a dumbbell shape, which could lead to significant issues, either decreased satiety or more reflux. And despite their best efforts, they had to be honest and say it was really only about 37% of the time that they actually got exactly what they wanted. Next slide. So his conclusion was, even though we attempted to achieve a tubular shape every single time, and all the procedures followed in identical surgical principles, despite that, the sleeve shapes were different. And they were only able to get tubular as, a little over a third of the time. In almost 2/3 of the time, they got something other than what they desired. And I think that's really the problem. I think that's the problem that we all face when we're doing a multi-fire technique, is that despite our best efforts, we can't get the ideal or the perfect sleeve with that current technique. And I think this next slide will kind of demonstrate why that is. Go ahead and advance. When we try to do a sleeve gastrectomy with multiple fires, every single time we need to make sure we get the tension anterior and posterior just perfect. And not only that, we need to get the tension from one staple fire to the next just perfect, because if you don't get that perfect every single time, you either wind up with too much stomach anteriorly or too much stomach posteriorly, or you've hugged the bougie a little bit tighter than you did on the last fire. And as I tell my residents and fellows, it's like each fire is really just trying to correct the slight mistake we made on the last fire. And when you're correcting mistakes on every time, it just multiplies and you wind up with these issues where you've got a little bit too much anterior, a little bit too much posterior, or the tension's not exactly perfect on every single one. Go ahead to the next slide. So we had an opportunity to look at our results, and we now have fired the stapler 1,700 times, but in September of this year, we presented our data of the first 1,361 cases using the Titan SGS Stapler. We started using it in September of 2021. As I said, these cases are all performed at 2 hospitals with 5 surgeons. We've got 1,316 patients who we included in this study, and we compared that then to the cases that we had done in the 4 years previously. So 5 surgeons, 3,800 cases done with the multi-fire technique, and compared that to the 1,300 patients that we have done since September of 21. Next slide. And this is our data on this. This is, as you can see in the demographic data, age was very similar, gender was very similar, BMI very similar, and even ASA classifications were all very similar between the two. So not any significant differences between the two in demographics. Next slide. And these were our results, and it was really kind of exciting because a few things that kind of stood out in the comparison. One, the Titan allowed us to easily transition to more outpatient surgery. And as you can see, surgical or the hospital time decreased significantly. And this decrease was really fortuitous as we were kind of, because of COVID, having to do outpatient surgery. And as we moved to more outpatient surgery, we saw that patients had significantly less postoperative nausea, and it allowed us to be able to get people out of the hospital much quicker. Our 30-day readmissions and reoperations decreased significantly, and our strictures became non-existent. And I think what was really cool is we saw the weight loss was the same, except for at 6 months, we saw maybe not quite as good a weight loss at 6 months, although at 1 year it was the same. And we really attributed this to the fact that because we're not having that post-operative nausea and vomiting, we didn't have that rapid weight loss at the beginning because patients were sick. So the weight loss was much more natural and really what I would say much more healthy. Next slide. I also want to show you the multi-center set collaborative data that we've got. These are from 6 different sites. The first 4,000 cases with the Titan at multiple sites, and compared it to bougie data or multi-fire bougie data from multiple sites in the years previous. And it was interesting because we saw a 27% reduction not only in operative time, which was significant, a 43% reduction in patient length of stay as people were transitioning to outpatient surgery. But we also saw, and this will be something that we're going to be studying more carefully in the future, significant reduction in GERD at 6 months. So I think what we're able to show is that with a better shaped sleeve, patients lose weight more comfortably and have significantly less GERD, which is a huge advantage, I believe. Let's move to the next slide. Well, we've heard, and I'm sure everybody's heard, there's discussion about, whether or not this thing is going to be better or worse than our current technique. What we can certainly say is multiple staple firings and reloads can be time consuming and potentially can increase the risk of complications and may lead to suboptimal surgical outcomes. Multiple staple fires can lead to a twisting of the sleeve, unwanted narrowing at the incisura, which can lead to postoperative dysphagia, nausea, vomiting, and reflux issues. Titan SGS Stapler certainly simplifies the process with a single fire, single use. Certainly in our study showed it saves time, and in the set collaborative data shows that it saves time. And I think now now we're like up to 10,000 fires. We certainly can say that the device is safe, it's effective, it's resulted in an improvement in outcomes regarding length of stay, readmission, reoperation, and stricture formation. Next slide. And in our study, at least with 1,300 patients, we certainly can say that using the Titan SGS Stapler in a very large cohort simplified our process. It was efficient. The stapler enhanced our safety and the effectiveness of sleeve gastrectomy, not only benefiting providers, but benefiting patients. The device is shown to be safe, effective, results in improvement in numerous perioperative outcomes, as well as considerable time savings. And we're excited to be doing further studies to look at GERD and reduction in postoperative GERD. Next slide. So some common concerns, anytime you bring a new device into the system, is it going to be reliable? Are there going to be increased risks associated with that from bleeding and for leaks? And I think we can put a lot of those concerns to ease now. Next slide. The Titan SGS Stapler has now been fired 10,000 times nationwide. And what we call the MAUD database, which is something that anybody can look up. It's the manufacturer and user facility device database. It tells you how many malfunctions there have been per fire. And the rate is 0.1%. So only 10 misfires in over 10,000 procedures. And I can't quote you what the other are, what they are for the other staplers, but I can tell you with certainty that rate is significantly lower than any other stapler on the market today. Next slide. The stapler, like I said, has had 10 reported postoperative bleeding events within 72 hours in a retrospective study of 2,800. That's a postoperative bleeding rate of only 0.35%, which is significantly lower than the published literature evaluating MBSA QIP reported incidence of postoperative bleeding and sleeve gastrectomies, which ranges anywhere from 0.6 to 1.1%. In our now 1,700 fires, we had 3 bleeds in the first 350, but since we've since the change in the stapler, we have not had a significant bleed or leak in the last now 1,350 cases. So we've been extremely excited. Next slide. The Titan stapler has had 9 reported leaks in 2,800 cases, leak rate of 0.31%, which compared to the published rates of leaks in sleeve gastrectomy using the traditional devices, which is a range from 0.3 to 0.9%. So I think MBSA QIP is like around 0.75%. So significantly less than that as well. Next slide. Just a reminder about staple fires and crossing staple lines. The FDA issued an updated guidance on surgical staplers in October of 21. The recommendation was a statement that there was increased risk of leak when a staple line was crossed, even if there may be clinical circumstances when a surgeon may deem it necessary or appropriate to do so. So just a warning about crossing staple lines, which, you know, is the thing we always have to do with a multi-fire technique, and that's something that we can get away with a new Titan. Next one. I know many people are concerned about buttressing, and the question always comes up, when will the buttress be available? We now have FDA approval for staple line reinforcement as of October 6th of 2023. So buttress will be available with the Titan in the very, very near future. So we're excited about that for those who really feel the need to buttress. We have not buttressed in 1,700 cases now, and not even with it available now, it'll be a real question of whether or not we think we need to do it. So what's the value? Certainly consistent sleeve pouch anatomy, reproducible from one patient to another. Reduced time of the procedure. One firing can lead to a repeatable sleeve gastrectomy every single time. A single staple line without overlapping staple lines reduces zigzags and malformed shapes. There's less chance of twisting or kinks in the sleeve pouch anatomy. I tell the residents, it's like kind of like when carpentry, when you measure 3 times and fire once. We can look at this anterior, posterior, longitudinal before we fire the stapler and make sure that that sleeve is just exactly the way we want it before we fire it from top to bottom, which really, really makes a big difference. Our hemostasis is definitely improved with this technique compared to the multi-fire technique. We've got in vivo studies that show that the burst strength is much better with this than it is with any other stapler. So also, should improve should decrease leak rates. And then I think, potentially we should see an overall procedure cost reduction because the cost of this is significantly less in most centers than if you do 5 or 6 staple fires. Characteristics of the stapler, just a beautiful instrument that fires it in one fire. Staple line height is changed from top to bottom, measured scientifically so that the staple is adjusted for that part of the stomach, which really gives us, I think, better hemostasis, which is nice. Next slide. And once again, demonstrating from 1.2 to 2.2 from top to bottom on the stomach. So as we all know, the cardia is in the upper part of the stomach is a little thinner than the lower part of the stomach. So having a staple height that's adjusted for each part of the stomach is really, really nice. And the next slide. So these are some studies looking at ex vivo leak pressures when you compare the Titan compared to both the other products, the Medtronic and Ethicon. Significantly better leak pressure, burst pressure, and significantly lower staple malform percentages with the Titan compared to the other manufacturers. All to give you more comfort. And then to finish, we're just going to have you see a few what we call reveals, just quick videos of one right after another, how the staple fire goes. So just to demonstrate the fact that, excuse me, one fire after another, you get the exact same result. Just a nice tubular stomach without twists or kinks. Oh, excuse me. And Hank, maybe while we're doing this, you could start to line up some questions if people have them.
That sounds great. So any questions from the audience, please enter it into the chat now, and after the video here, we will move on to the Q&A. Well, thank you, Dr. Schram. I really appreciate you
Absolutely.
sharing your data and your presentation there with us. So, one question for you here is that earlier in the presentation, you discussed from y'all's study of over 1,300 patients, your length of stay, and it looked like it almost cut it in half.
Yeah.
So from how really how has that changed your algorithm and how y'all look at doing outpatient sleeves versus what you were previously doing inpatient?
I think before we were nervous about doing outpatient sleeves. It's hard to predict which patients are going to have nausea, which ones are going to have, vomiting, and to send a patient home, the same day with that concern about how much nausea and vomiting they're going to have is probably the biggest, significant factor of can they go home or not. And it was unreliable. And I think what this has allowed us to do is have tremendous reliability that the patient is not going to be nauseous or have vomiting from a technique related problem. I mean, when you can give that patient, a perfect tubular sleeve every single time, you can be really much more confident that they're not going to have any, technique related issues. So that just gave us a lot more comfort about it, and at the same time, there became much more pressure from insurance, but also, from COVID and hospitals full of people to get people out sooner as well. So, but having the Titan at that time really just allowed us to have much more comfort in being able to do it.
Great. Well, another question here from the chat is, how many cases did it take for you to get through your learning curve, or where you felt like you were comfortable getting through your learning curve?
Yeah, I would say less than 10. Now, having said that, in our group, in the first 6 or 7 months, we were using what we would, the Titan R, and we switched over to the RB, which provided a little bit better compression after about 6 or 7 months. And I would say our comfort level was better with the RB without a buttress material. So although the technique was easier to learn, our comfort level went up significantly when we had that better compression with a newer stapler model.
Right. And another question here regarding the bougie. So I know you have an extensive experience with the standard bougie and just, really kind of understanding like why you made the change to that and then what the clinically you have seen from outcomes and any technique suggestions on that.
Sure. So, I mean, stricturing at the incisura is, something everyone fears. And, with a regular bougie, you do your best. But if you get a little bit too much pressure or tension, on the bougie when you're coming around that incisura, stricturing is a very real thing. The beauty of this bougie with the balloon, which we can stick right at that incisura, it's about 3 inches long or 3.5 inches long, and we place that right at the incisura, and that takes that, up from a 38 French to about a 42, 44 French. And having that right at the incisura just gives you a world of comfort that you can't get too tight at the incisura. And we haven't had, in now over 2 years, we haven't had a single stricture at the incisura with 1,700 cases now. So it's spectacular for us.
Well, that's fantastic. Well, with that, we will conclude our webinar for this evening. I appreciate all of you for joining in, and most of all, thank you, Dr. Schram, for sharing your experience with us, and we look forward to talking to you again here soon.
Hey, thanks very much for having us. We appreciate it.
Thanks.